Hi, I'm Rachel, and I'm here with Delaney and Sydney to talk about traumatic brain injury lower functioning. So, a traumatic brain injury is any altercation in the brain that is caused by an external force. It has to include at least one of the following symptoms: so loss of consciousness, post-traumatic amnesia, disorientation and confusion, or other neurological signs such as getting a positive neuroimaging scan. It's important to remember that with this injury, there can be a wide variety of symptoms, and every individual client is gonna recover differently. There are 3 different levels to a TBI. So a mild traumatic brain injury is like the least severe one. It is less than 30 minutes of loss of consciousness, less than 24 hours of post-traumatic amnesia, disorientation and confusion lasts less than 24 hours, and the patient will have a GCS score of 13 to 15. Then we have moderate TBI, which is 30 minutes to 24 hours of loss of consciousness, 24 hours to 7 days of post-traumatic amnesia, and then a GCS score of 9 to 12. And then the most severe is severe traumatic brain injury, which is more than 24 hours of loss of consciousness, more than 7 days of post-traumatic amnesia, and a GCS score of 3 to 8. Some medical complications that come with a TBI can be coma, seizures, hydrocephalus, which is an increased fluid in the brain. So that's important to us because we'll have to position the client in the bed with their head higher whenever they have this. Dysautonomia, and they could be in a vegetative state. Some sensory motor deficits are the deceperate and decorticate rigidity, and there's pictures of them. And they could also have spasticity, hyper or hyporeflexia, tremors, impaired motor planning, edema, contractures. They could also have some visual deficits, so some double vision, nystagmus, and decreased ocular motor skills. For visual perceptual deficits, they could have pattern recognition issues, figure ground perception issues, unilateral inattention. They could have visual memory deficits, etc. And then for cognitive, they'll have difficulty with orientation, attention, processing. They'll have anterograde or retrograde amnesia. They could have long-term memory loss and difficulties with executive functioning. And then also with TBI, it's important to look at the psychosocial impairments because they will most likely have impulsivity, agitation, aggression. They could have PTSD that could result in nightmares and anxiety. And overall, with these symptoms, it's just important to look at the specific client to see what they have because it could be a wide range.
Our first assessment we looked at was the performance assessment of self-care skills, the PASS. Generally, it takes 3 hours to administer. And the purpose is basically to have a holistic snapshot of the person-task environment and the client's ability to live independently and safely in their community or home, just based on various ADLs and IADLs. The things that are measured are independence, adequacy, and safety. There are 26 tasks in 4 different domains, measuring functional mobility, ADLs, IADLs, with physical emphasis and cognitive emphasis. And the rationale is to get a baseline for functional ability and safety in order to create intervention plans. It's also helpful to show improvement. The next assessment we looked at was the mini mental state exam, the MMSE. It's a standardized 11-question test that assesses the cognitive ability of a person in 6 different areas. These areas are proprioception, attention, concentration, short-term memory, language skills, visual and spatial relations between objects, and the ability to understand and follow instructions. takes about 5 to 10 minutes to complete for easy retesting. The rationale on why we chose this one is basically to get a baseline for cognition so we know where we were starting with the patient, and it also allows us to show improvement with retesting. The last assessment we looked at was the agitated behavioral scale. This assessment measures the behavioral aspects of agitation during the acute phase of a TBI. It takes about 30 minutes to administer, and 14 different items are assessed. The minimum score that can be given is a 14 and the max score of 56. And below is the scale of just kind of how you would grade those throughout the assessment. The rationale is that agitation is a very common symptom with TBI, and it can influence how we treat our patients, so we need to know where they are at on the specific scale.
Some of the interventions that we looked at were range of motion. Inactivity and immobility will reduce joint mobility, tissue flexibility, and physical ability. Passive, active, or facilitated range of motion exercises. Passive stretching, positioning, splinting, and bracing. Joint mobilization, and the use of heat. The rationale that we had for this is because we don't want them to be stiff or any loss of range of motion during their hospital or a period of immobility. Our second one is the cognitive orientation to daily occupational performance. This is a performance-based treatment for individuals who experience difficulty performing skills that they want and need to do. Go, plan, do, check. Skill acquisition, development of cognitive strategies, generalization of skills and strategies to everyday life, transfer of learning to new skills and contexts, employs collaborative, goal-setting, dynamic performance and analysis, cognitive strategy use, guided discovery, and enables principles. Continuing what we want to do, plan how we want to go and do it, carry out the task, check how we want to plan the work, and then tips, provide just right challenge to ensure success with errorless learning, prompt with cues, and use memory aid. Our rationale for this is that we want our clients to learn skills that they can take it home, and then it allows them to increase their cognitive independence. Our third is psychosocial education, group therapy for common emotional symptoms associated with TBI, such as anger or depression, and potential impacts of a TBI, such as changes in professional life or difficulty in relationships. Provide training on coping mechanisms, provide training on self-management strategies for anger, self-monitoring skills, identifying emotions, and active listening. Just with TBI, it's such a big injury that it can affect people in many ways, one of which is emotionally, and we need to make sure that they're also focused on that and also the patient's mental health as well. And then these are our references.